Next, we'll be talking about blunt trauma. So, what are the various modes of injury of a blunt trauma? It can be either a direct blow, which occurs with a fist, a ball, or any other blunt object. So, all of these types of injuries can cause a direct blow. Accidental blunt trauma is most commonly seen in cases of road traffic accidents. So, these are the broad modes of injury of blunt ocular trauma. What is the mechanism of injury in these cases? There are various mechanisms of injury. So first one is if there is a direct impact on the globe. So when a blunt object comes in contact with the eye, it can cause a direct impact. So what this does is it produces maximum damage at the point where the blow occurs. So we can see here the trauma is happening on the cornea, and that is where the maximum changes happen. That is basically your direct impact on the globe. The next is the compression wave force. So what is happening here is the force of trauma. Here the force is transmitted through the fluid contents, and it goes and strikes the angle of anterior chamber and pushes the iris lens diaphragm posteriorly. So your iris and your lens are being pushed posteriorly, and that wave force also goes and strikes the retina and the choroid posteriorly. So there is damage to the angle of anterior chamber, the iris lens diaphragm is going back, and your retina and choroid are also getting damaged. So this picture depicts exactly what is going on there. There is another concept of counter coup damage which you need to know here. It is basically a concept where maximum damage is produced at a point distant from the actual place of impact due to an excessive compressive force. So counter coup damage is basically the damage is happening somewhere else and trauma is happening at some other point. So that is what we mean by a counter coup damage. So that is again a type of compression wave force. Next is a reflected compression wave force. So as the term tells you, it is reflected. So the wave is being reflected from one layer of the eye. So after striking the outer coats, the compression waves are reflected towards the posterior pole. So posterior pole damage causes severe amount of foveal damage. So fovea is extremely important because that is the place for your majority of your visual acuity. Okay, so foveal damage causes a significant reduction in vision. So this is your reflected compression wave force. And lastly, you have your rebound compression wave force, where the wave force is rebounding from the posterior wall. So after striking the posterior wall, the compression waves rebound anteriorly. It damages the retina and choroid by a forward pull, and the iris lens diaphragm is also damaged with a forward thrust from behind. So retina and choroid are damaged because of a forward pull, and iris lens diaphragm is also damaged because of the posterior thrust which is coming onto the iris lens diaphragm from behind. So these are all the different mechanisms of blunt ocular injury. Next, we need to know what all of these mechanisms can cause. What are the different lesions or manifestations of blunt ocular trauma? So again, we have classified them into three groups. You have manifestations which with a intact globe or a closed globe injury. Next is a globe rupture, and lastly, you have the extraocular lesion. So blunt injury can cause all of these manifestations. So we'll first talk about blunt trauma manifestations with a closed globe injury. Again, we will go part by part, so that will be easier to remember. So what are the changes which can happen on the conjunctiva? So we can have a subconjunctival hemorrhage. What exactly is subconjunctival hemorrhage? It's basically accumulation of blood in the subconjunctival space. Okay. So there are few blood vessels which are present in the subconjunctival space. So if there is any form of injury, those vessels open up and you can see a dark red patch over here. So that is one of the common manifestations on the conjunctiva in cases of blunt ocular trauma. There is no active intervention which is needed here. Most subconjunctival hemorrhages resolve over 10 to 2 weeks, 10 days to 2 weeks. So what is important is we need to assess if this trauma has caused any posterior damage. We need to examine the retina in most of these cases. So that is your subconjunctival hemorrhage. Trauma can also cause some amount of conjunctival chemosis and conjunctival tears as well. So these are all manifestations which we see on the conjunctiva. The cornea, the manifestations include corneal aberration. These are basically lesions which you see on the corneal surface because of ocular injury. You can also see some forms of epithelial defects as we see in this picture here. Lamellar lacerations. So the term lamellar is pretty important here because it's not a full thickness injury which is happening. It's a partial thickness wound. So we call it as a lamellar laceration. Lastly is a blood staining of the cornea. So why is there blood staining of the cornea? This is basically because of hyphema. Hyphema is basically blood in the anterior chamber which is coming in contact with the inner surface of the cornea. And this has to be takes place along with the increase in intraocular pressure. So hyphema and raised IOP are together responsible for blood staining of the cornea. The cornea appears reddish brown in color as we see in the picture here, and it starts slowly clearing from the periphery to the center. So this is your blood staining of the cornea. These are your corneal manifestations. What do we see on the sclera? Sclera, again you see a few tears or lamellar lacerations. You can see a few injuries which can be seen here. So these are your lamellar lacerations on the sclera. Next is your anterior chamber. So one of the most common manifestations that you see is a traumatic hyphema. So hyphema is basically collection of blood in the anterior chamber. So from where is the blood coming from? It is from the iris. Okay, you have a vascular structure in the eye there. The iris, the ciliary body and the choroid which together forms a uveal tissue. So blood comes from there and starts to accumulate in the anterior chamber. So what you see here is accumulation of blood in the anterior chamber. So this accumulation of blood can cause a increase in intraocular pressure. So it's very important to see to it that this hyphema resolves as soon as possible. So we need to start patients on topical anti-inflammatories like steroids, and also start patients on topical cycloplegics like atropine or hometropine, so that the pupil is pretty mobile and the hyphema resolves. But there will be some situations where the hyphema doesn't resolve. In those cases, you need to take the patient to the operation theatre, make a small paracentesis or a side port wound right here, and drain the blood from the anterior chamber. Apart from that, we can also see some amount of inflammation like cells, flares and exudates in the anterior chamber, which are the other manifestations that you see in the anterior chamber in cases of blunt ocular injury. Next, we'll talk about manifestations in the iris, pupil and ciliary body. So what is traumatic meiosis? So whenever there is a trauma, there is a sudden constriction of pupil. So that is what we call as a traumatic meiosis. This is usually followed by a pupillary dilatation. So that is what we call as a traumatic mydriasis. So you can see a small pupil here which is meiotic, and a large dilated pupil which suggests there is traumatic mydriasis. Other manifestations include iridodialysis or a D-shaped pupil, what you see here. So it is a detachment of the iris from its root. So the iris is being detached from here and you see a nice D-shaped pupil here. Next is anteflexion of the iris, which is basically rotation of the detached portion of the iris where the posterior surface faces anteriorly due to an extensive iridodialysis. So that is what we mean by anteflexion. Retroflexion is basically where the whole of the iris is doubled back into the ciliary region. So the entire iris gets turned into a ball and it curls back into the ciliary region. There can also be situations where the entire iris can be detached, and you will see a situation called as traumatic aniridia where there is no iris anywhere. So these are all common manifestations of the iris and ciliary body. Next is angle recession. So what exactly is angle recession? Angle recession is basically a tear between the longitudinal and circular muscle fibers of the ciliary body. How do we diagnose this? Usually when we do a slit lamp examination, the anterior chamber will be a little deep and there will be widening of the ciliary body band, which we see on gonioscopy. Now normally when we do a gonioscopy, these are the structures that you see. The Schwalbe's line, the trabecular meshwork again is of two types, the non-pigmented, pigmented, the scleral spur and the ciliary body band. Okay, so but whenever there is an angle recession, you will see that this is pretty narrow, whereas the ciliary body here is pretty wide. So that is something that you see on a gonioscopy. Now what this can cause is an increase in intraocular pressure later. That is why this is of significance. So this is called angle recession glaucoma, which can happen later. So this needs to be managed. What do we see on the lens? A lens, one of the classical manifestations that we see is the Washes ring. What exactly is a Washes ring? It's basically the pupillary margin going and hitting the lens, anterior capsule of the lens. So we will see some amount of pigmentation which comes from the pupillary margin on the anterior lens capsule. So you see a nice ring of pigmentation on the lens. So that is what we call as a Washes ring. So usually it will be a little smaller than the pupillary diameter, because usually when there is initial trauma, there will be a little constriction of pupil. So later on, when you see some amount of traumatic mydriasis, you will see the Washes ring properly. So this is what you mean by Washes ring. It is basically a manifestation on the anterior lens capsule in cases of blunt ocular injury. Next is a concussion cataract. So concussion, the type of cataract that you see in trauma is called as a concussion cataract. So it will be usually along the suture lines, and it gives the appearance of a rosette shape. So it's also called a rosette shaped cataract. It can be again early or delayed onset type of rosette cataract. The other manifestation on the lens that we can see are subluxation or a dislocation. So what do we mean by subluxation of lens? Subluxation is where the lens has moved from the pupillary area, but some amount of zonules are still intact. Now we know that the lens is kept in position by the zonular fibers which connect the equator of the lens to the ciliary body. So whenever there is any trauma, there can be a loss of the zonular fibers here. So the lens can just shift, but it still stays in the pupillary area because some amount of zonules are still there. What happens in dislocation is the entire zonular support is lost, and that time the lens can either come entirely into the anterior chamber or it can also drop into the vitreous cavity. Sometimes the lens can get accumulated, can move into the subconjunctival space. In that case, we call it as a phacoseal. Phacoseal is basically a lens in the subconjunctival space, which is again a manifestation of a blunt ocular injury.